Dr. Patel will give us an overview of subarachnoid hemorrhage, natural history, and summary of latest aneurysm trials.
Good afternoon. Sorry for the delay. I was stuck in traffic coming down from uptown. But I'd like to thank Alan for inviting me to this and giving me a grand total of 9 minutes to go through this fairly large topic. So I will be brief and summarize and before Dorothea kicks me off. Is there a pointer here or anything like that? Okay. So just going through a little bit about the natural history of subarachnoid hemorrhage. The risk factors for aneurysm formation, cigarette smoking is the single most preventable factor, and it's a dose-dependent effect. The more someone smokes, the higher the risk of increasing the size of aneurysm, the higher the risk of subarachnoid hemorrhage. Hypertension, moderate to heavy alcohol use, cocaine use. It's important for people who come in with hemorrhage after a night of partying. If they have a hemorrhage, especially after doing cocaine, 50% of those patients will have an angiographic lesion. So we tend to angio most of those patients. Obviously, if you've had a prior subarachnoid hemorrhage, you have a much higher risk of having a future subarachnoid hemorrhage. And patients with previously treated aneurysms will have a rate of new aneurysm formation of 1 to 2% annually. Looking a little bit about the epidemiology of subarachnoid hemorrhage, in 2003, there were 31,476 discharges in the U.S. From subarachnoid hemorrhage, which had increased from 25,000 in 1990, which comes out to a rate of about 14.5 per 100,000 adults. The prime age is between the ages of 40 and 60. 12% of patients die before reaching the hospital. 12% of patients are misdiagnosed. 25% of patients die in the hospital, and the 30-day mortality is 45%, which is bad. The outcome: 25 to 40% of patients who survive do not return to work, and 60% of these patients report changes in personality, which is underreported in the older literature from surgical clipping. But as we start to know a lot more about the neurocognitive effects, these are real and they do occur. There's a higher rate of depression in these patients, and really only 25% of patients report no neurological or psychological sequelae. What are the predictors of poor outcome? The modifiable factors are rebleeding. I think we've sort of handled the rebleeding